I would like to introduce our next speaker, Robert Stroud, Chief Perfusionist at Maimonides Medical Center. Please.
Yeah, my name is Robert Stroud. I am the Chief of Perfusion at Maimonides Medical Center in Brooklyn, New York, and it's a true pleasure to be here to speak about the new Chalice CM08 oxygenator. As for disclosures, I haven't been funded by Chalice for this talk, not yet anyway. It doesn't mean that the check's in the mail. It just means I'm very involved in medical missions. I've done over 75 cardiac mission trips, and as a manufacturer, I will go to them and ask for them for support. So I thought I would at least disclose that here. And the legal department and risk management of Maimonides always wants me to let people know that when we do ECMO, it's off-label use. So that statement is there to satisfy them. A little bit about the program at Maimonides. For adult cardiac cases, we do about 600 a year. We do everything except for transplants. We do about 40 ECMOs on an annual basis. We do have an ECMO to go program, which means we go to local hospitals, put patients on support, and bring them back to the hospital. For initiation and discontinuation of support, it's always a perfusionist, a surgeon, most of the times a PA, and sometimes the ECMO coordinator will go along. Perfusion does not sit bedside at our facility. Instead, we have ECMO specialist nurses that manage the patient, and our institution has been awarded the gold level of ELSO certification. I've been doing perfusion for 36 years now. 25 of that has been involved somewhat in some type of ECMO. First started back in the early 2000s with the SciMed flat plate membrane oxygenator. That thing was a pain in the butt to debubble. You could CO2 flush it, you could vacuum prime it, you had to run flows high, but it was what was available at the time. And we had to build a bridge around it because inevitably, usually within their 6 or 7 days, it would start to fail and we'd have to change it out. 2014, we started an ECMO program at Maimonides with the invention of the polymethylpentene oxygenators, started using Midos. Then we went to Quadrox. Quadrox was our primary oxygenator during COVID. We actually had a 36-year-old male on VV ECMO for 9 months, and we supported him with this oxygenator until we got a lung transplant at NYU Hospital. Once Quadrox was no longer available to us, we went to Urosets, and now we're using the Chalice. The thing with a Chalice, it is completely different than what we had seen before. The other oxygenators, I could call up another perfusion chief, I could call another institution and say, hey, how's the Quadrox work? What have you seen with the Euroset? What are the good, the bad, those kind of things? Well, with the Chalice, we didn't have any of that, okay? So the surgeon said, if we're gonna use this, we gotta get some data, okay? And you as a perfusionist, you're gonna have to focus on this oxygenator when we first start to use it. So started to think back, well, how am I gonna get this data? What data am I gonna use? Our hospital has training sessions for research. And so I was hearkening back to some of the research classes that I had taken at the hospital. And then I'm going to share some of that with you today, and it sort of helped me figure out the data that we're going to get and how we're going to focus on that data. So this is one of the data presentations that was brought up at the training session. This was done by the Air Force right after World War II. And the instructor in the session said, look at this, all these dots that you see on here are where planes that came back from battle had some kind of damage. And the Air Force, what they wanted to do was figure out where's the best place on these planes that we can enhance the metal so in future battles, the planes will be more sustained. So people in the crowd, probably about this size crowd, I was out there, and people were saying, well, most of the hits were in the middle, so maybe they should reinforce it there. Some people said, well, no, it should be the wings or the tail because that's what controls most of the plane. And if you get hit there, there's going to be some control issues. So I'm listening. So very shyly I said, hey, Rob Stroud, perfusion department, cardiac surgery. I'm looking at this data, And from what you told me, I think you should reinforce mid-wing, mid-tail, and up by the propellers. And the reason being, you're telling me that all these marks are from planes that came back. Okay? I'm not worried about the planes that came back. I'm worried about the planes that didn't come back. So I'm surmising that they got hit mid-wing, mid-tail, and up by the propellers. And as it turned out, the perfusionist in the room was correct. Right. So let's talk about this oxygenator. All right, this is what it looks like. We had a specialist from the UK come and talk to us about the oxygenator, so we would be familiar with it. This was all part of the data collection that we had. Okay. So the first thing you're going to look at is, okay, does it have the right connections? Does it have the right in and out tubing size? Does it have the right in and out connections for our heater cooler? Is it the same connections for the blood path and for the oxygen or gas path? Right? And sure enough, it does. So we looked at it, and you can see, as a perfusionist, we're looking at, is there a countercurrent mechanism between the blood flow and the water flow on the heat exchanger side? And there is. So we know we're going to have an efficient heat exchange coefficient. And we also looked, how's the flow of gas going in relation to the blood flow? Is it countercurrent? Yes, it is. So we know we're going to have a good O2 addition and CO2 removal. The next question we had was, well, what's the configuration of the fibers? Are they up and down? Are they across? Are they left or right? Are they sort of like a cross match, overlapping each other? Well, the fibers in here go up and down, and that allowed for, from our opinion, would allow for a little bit easier flow across the membrane and a little bit less resistance. All right. And if you look on the left side, you can see the blood flow goes in at the top. There's also a port up there that you can use for pre-membrane samples. You can use it for a pre-membrane pressure measurement if you do so. And also at the very top there during priming, if any kind of air gets in, you can very easily withdraw the air from that port. As the blood exits the oxygenator, you can see it goes in, goes down, comes up to the top, and at the top there's a little bit of a dome. If any air would get through the membrane, it'll capture in the dome, and then you can easily withdraw that with a syringe as well. As it exits the bottom of the oxygenator, there's another port there that you can use for post-membrane pressure measurement, or you can also use it for a post-oxygenator sample. And there's also a temperature port there. So then we looked into the IFU. It's intended for 6 hours of use, blood flow 1 to 7 liters per minute, priming volume of 300 milliliters. And the thing that was pretty significant for us was the surface area. The other oxygenators that I had mentioned that we had used all had a surface area of about 1.8 meters squared. This one has 2.47, so about 25% greater surface area. Now, it does come with a little bit higher prime volume, somewhere between 50 and 75 milliliters more than the other oxygenators we were used to, but we're an all-adult center, so an extra 50 or 75 milliliters was really insignificant for us. Once you order the packet, it comes in a tray like this. The components in there are the oxygenator, a reservoir, a prime bag, AV loop, gas filter, and some quick connects. Next thing we asked, well, is there a coated surface, and is everything coated? And it is. This is a proprietary formulation that Chalice has, and they actually use it on their other oxygenators that they use over in England. So it's been proven, tried and true, so we were happy to see that. Okay. The other thing that facilitates air removal is the way the oxygenator is situated in the holder. It's actually tilted at a 5-degree angle. And this is what it looks like in our system. Okay. Anytime we get a new oxygenator in, we try to make that the only variable. So if you look on here, you're going to see we're not really using their tubing pack. The reason being, we wanted to make sure the only thing that has changed is the oxygenator so we can assess everything else. Right? Our tubing pack is a little bit different. We do have a custom tubing pack. It's specific length for our VA or VV ECMO patients. We also do have pre and post connectors with Roberts clamps on there, and you can see there are, on the pigtails, there's a blue one and a red one. That's to facilitate the hookup of the CVVH machine in the CTICU. And this is what it looks like in use on a patient, and you can see there that we always do hook up heater cooler to our oxygen, to the oxygen system into the ECMO circuit. Right? Now, one of our protocols is that we never go below a 2.0 sweep. Okay? And this is specific for the CTIC nurses. They're taught this in education sessions every year. And it's just a safety factor, so we know that we're never going to go below that. Right? Well, we've sort of had to change that protocol with this new oxygenator. I'll show you that in just a moment. So what is our protocol at MIMO? We use 5,000 units of heparin on all patients upon initiation. Target flow is an initial target flow is 2.0 index. We usually go on to 2.0, quickly go up. We started at a 1-to-1 flow to sweep flow ratio. We do anticoagulate the patients, PTT 60 to 80 with either heparin or gadraban. We do pre and post oxygenator samples. And since the inception of our program back in 2014, we have never measured pressure drop. We look at other things, whether it's LDH or performance of the oxygenator to tell whether or not it's time to change it out. All right. So today we have used 25 of these oxygenators. We have handheld blood gas analyzers that we take with us to measure upon initiation. We'll do a post-oxygenator sample, and consistently the PO2s are above 500. And when we do the 1-to-1 sweep flow ratio, the CO2s are below 30. And the last line is the thing that's most significant that we've seen. We have had 0 change-outs with this oxygenator. So how did we do this? Well, we knew we had to focus. The surgeon said, listen, you have to focus on this oxygenator. Okay? And so I went back to those research and training classes that I had, and I thought, what's the best way to figure out how as a clinician do we focus? How do we pay attention to things? So I have this little video I'm going to show you, and it's going to tell you a little bit about yourself. There's no right or wrong, but it's going to tell you a little bit about yourself, about how you focus and how you pay attention. All right, so it says there, okay, the correct answer is 15 passes. Okay, you're going to understand that in just a moment. But what I want you to figure out is they're telling you the correct answer is 15. I want you to focus and really determine whether or not 15 is in fact the correct number of passes.
This is a test of selective attention. Count how many times the players wearing white passed the basketball. How many passes did you count?
How much did we get?
The correct answer.
So the correct answer is 15. Okay.
Answer is 15 passes. But did you see the gorilla?
All right, see the gorilla coming in? All right, so how many people saw the gorilla the first time? Yeah, the first time I didn't. Okay. I was so focused on counting how many passes. I wanted to get it right. The instructor was like, yeah, I'm going to get this right. Perfusion's always right. And that made me realize, okay, focusing on just the oxygenator, like the surgeon had told us, about 10 uses into this oxygenator, we started to get a little bit of a shift. Well, you know, we're getting a lot of consistency with this oxygenator, so let's start to focus not just on the oxygenator, let's see the gorilla. Let's start to see how we can use this to manage the patient a little bit better, right? So this is the first patient we did. And I'm not going to go over all 25. I'm just going to have 3 patients here and then give you the data on it. First patient was VV ECMO. Before we got to the SICU, there was a blood gas drawn, pH was 7.0, CO2 was 90, and arterial sat was, you know, just below 80%. Patient was a 2.0 BSA. We initiated support, went on to 4 liters flow, 4 on the sweep. Now we don't have a blender when we go up to the units or on an ECMO to go. It's just either wall, 100% wall oxygen or from the O2 tank. So we had that on 4, had the blood gas analyzer with us, took a post-membrane sample, and you can see the PO2 was 525 and the CO2 was 23. So obviously the sweep was a little bit lower than we wanted. If we have students in here, they should know the calculation. You take the actual CO2 divided by the divided by the desired CO2, multiplied by the current sweep flow, and you get a number of where you should turn your sweep to. Well, we turned it down to 2, and 2 is actually, remember, according to our protocol, the lowest we were going to go. So then we took a gas from the radio arterial line, pH 7.35, CO2 was 45, and the O2 was 189. So we were happy with the results. Next patient we put on was also a VV ECMO. This was a little bit smaller patient. So based on the information that we had on the first patient and starting, we didn't go to a 1-to-1 ratio. We were flowing just over 3.5 liters and 100% FiO2, and so we had to sweep at 1. So post-oxygenator gas, 7.6, 23, 518, 519 on the O2. So we did adjust the sweep down even lower, okay? So this is day 2 with the oxygenator. Took post-membrane gas, pH is good, CO2 is good, PO2 is good. And this is all allowing for great physiological results on the radial line. Day 3, same FiO2 and sweep. And you can see we're still maintaining good CO2 removal and good O2 addition. Okay. Now, for data purposes and comparison purposes, we had a patient in the ICU bed next to this patient that we had put on VA ECMO. And this was with a different oxygenator, and this is just for data purposes. Okay. Day 1, flowing 4 liters a minute. We had the sweep at 4. And you can see that pH was 7.49, CO2 was good, and you can see the O2 is 222. Right? So it's just a little bit different in the efficiency between the 2 oxygenators that we had in-house. So we did have to change our protocol. We no longer have a limit of 2.0. So now we're looking at how we can manage patients a little bit better with this new oxygenator. We have retrofit our ECMO to go circuit to accommodate the oxygenator. That's what our carrying case looks like. It's got the motor, the case, obviously the console, and then that bag that you see beside it. It's a rolling bag that has everything and anything you could ever want to put a patient on ECMO. Okay. And this is just last week, the final slide. We had a patient on VA support. I got a call around 6:30 in the morning. Patient had been on for 10 days, and the surgeon wanted me to do a pre and post oxygenator sample. Went over to the units. Patient was at 3.5 liters, sweep was 1.5, and FiO2 at 100%. So I get in there and I start to get ready to take the blood gas samples, and the night nurse is now talking to the day nurse because they're switching over. They're in the room, they want to see the results. They call in the NP, night NP, so now that nurse is in. They call in the intensivist who is in overnight, so now they're there. And now 2 surgeons are come in to see what's going on. And I'm looking around, I'm like, I've done this like 1,000 times. I really appreciate the support of everybody being in here, but am I missing something? They said, well, we had an issue overnight. We're trying to, control the patient, and our saturation is just not where we want it to on the monitor. So it's setting, around 95, 93 or whatever, and they prefer 98, nurses do, which is fine. So based on past knowledge, they're thinking that the oxygenator is failing, all right? So as a perfusionist, when you walk in, you have, what did Bruce call that, the bias? You walk in, I can look at it, and I can see that oxygenator is not failing. I can see it going in dark, and I can see it coming out bright red. So still, nurses are saying, we just don't know. We think it's the oxygenator. So, okay, so we took a pre and post, okay? And if you look here on the pre and post, pre-gas, okay, good pH, CO2 is okay, O2 is a little low, saturation is 64, a little bit low for me. On the arterial side, we've got a good pH, okay, CO2 is good, and we're definitely oxygenating, all right? So the question was, how do we handle this patient? So what would you do as a perfusion if you walked in here and you saw this? What would you do? What would you do with that? Let me ask the students. What would you do with that saturation of 64 on your venous side? They are sedated, and that was one of the suggestions, should we sedate them more? They are not fibrous, they're not febrile. Good question. What else might you do? Okay, change vent settings. How about turn up flow? Well, we would do that on bypass, right? Okay. The other thing you could do that you brought up, febrile, the patient wasn't febrile, but we do keep a heater cooler on. Other thing you can do that was suggested is you turn down the temperature. We always maintain around 37 degrees. So if you turn it down 2 degrees, everybody knows for 1 degree centigrade, you drop the patient's temperature, metabolism drops by 7%. So if we went from 37 to 35, we're going to drop the metabolism by 14%. Not a lot, but it's going to help the patient. So we did. We went up on flow a little bit, dropped the temperature a little bit, and it was much better for the patient. When our chief cardiac surgeon, who's also in charge of the ECMO program, came around, he wanted to make sure that the nurses understood that going forward, we need, for the first 10 days, to take oxygenator failure out of the equation, all right? So that's a little bit of a paradigm shift, that we're seeing now at our hospital based on using this oxygenator. I'd like to thank Chalice Medical for all their support, Philip, Jeff, Lee, Ellen Reeves, our ECMO coordinator, Dr. Paul Saunders, our chief of cardiac surgery, and the Maimonides perfusion team, Linda Holm, who's here, Mike Mayo, Darren Parham, Ifra Salim, and Jared Beinstock. I learned at a very early age, if you surround yourself by good people, you look good yourself. And the only reason I look good is because of those five people you see and the team that I work with on a daily basis. Thank you, and I'd open for questions.
Thank you, Robert, for a nice talk. Unfortunately, we have time just for one question. So, please.
Thank you for your presentation. My quick question is, how long was the oxygenator used for? What's the maximum run?
Oh, good question. Yes, longest one was 21 days.
21 days?
Yeah.
And no issues?
No, actually on that one, the lowest we saw for PO2 was, I think it was 368 when we did a post-membrane sample.
Great, because I just got them in. We just used one oxygenator, but it was only for less than 24 hours. The patient didn't make it. So we have 2 more on the shelf, and just, I know, did you have any issues with priming? Because the first one we used, I wasn't there, one of my staff used it, and she said she did have some, it wasn't as easy to prime, so I don't know how you guys ended up priming it. I'm gonna try to do it the next one to see what the difference is.
We didn't have any issues with priming. I mean, there's gonna be a little bit of, air that gets captured in the areas that they're supposed to, but they were easily removed. And once it was done priming, we didn't have any residual air that we were concerned about.
Okay. One last thing, how come you guys do the limit for sweep of 2?
It's just for nursing. It's actually not for perfusion, but it's for nursing because we don't want them to play with the dial. And some people think 2 is here and 2 is here, depending where the ball is. And it's just a protocol for nursing. Don't go below that. And the surgeon will make the decision if we need to go below there. That's all.
Great. Thank you.
Mm-hmm.
Thank you so much, Robert. Thank you.